Welcome to the deep dive. Today we're stepping into a world that, well, for many of us, it evokes this profound mix of wonder and, let's be honest, sometimes a little bit of anxiety. We're talking about the health of our children. Think about those moments a baby's first giggle, or the sheer determination in a toddler's wobbly first steps, or maybe the rapid-fire questions from a school-aged kid.
Right.
It's this constant, pretty miraculous transformation. But, when they're sick or hurt, that sense of wonder can quickly flip to, well, overwhelming concern.
Absolutely. It's a totally different feeling.
And here's the thing, the crucial insight that I think often gets overlooked. Caring for children isn't just like a smaller version of adult care.
No, not at all.
It's a completely different universe, really, with its own unique rules, its own challenges, and incredible intricacies. So today, we're about to unravel that intricate and fascinating world of pediatric care. Our sources for this deep dive, they include comprehensive guides covering, well, everything from specialized pediatric assessment and common illnesses to pain management strategies, tracking developmental milestones, and understanding a range of specific disorders.
Yeah, quite a range.
We've got a lot to explore, and it's really designed to give you those aha moments, the kind you won't soon forget.
And our mission for this deep dive is really to equip you with a foundational understanding of what makes pediatric health truly unique, why these specific approaches are so crucial, and, how healthcare providers actually navigate these complexities day to day.
Yeah.
Think of it as maybe a shortcut to being genuinely well-informed, offering some surprising facts and practical insights that will hopefully deepen your appreciation for child health.
That's exactly our goal. We'll journey through, well, everything. From the philosophy of centering care around children and their families, which is key, to the really crucial differences in their tiny airways compared to ours. How we assess pain in someone who literally can't tell us how they feel.
Yeah, that's a big one.
And what critical markers to look for as they grow. It's truly a specialized field, and we're here to guide you through its most important nuances. Okay, let's unpack this right from the start. When we talk about pediatric care, especially, in a clinical setting, there's an absolutely essential role right at the forefront: the pediatric nurse.
Definitely.
What exactly is their role? Because I think for many people, it's far more expansive than just giving shots, which is often the first thing that pops into mind, right?
You're absolutely right. Yeah, shots are vital, definitely, but it's just one small piece of a much larger, much more holistic picture. The primary responsibility of a pediatric nurse is centered squarely on the child and their family. They're seen as the direct consumers of care. And this isn't just like a nice-to-have philosophy. It's fundamental.
Right.
Their functions are incredibly broad and deeply interconnected. For instance, they're heavily involved in health promotion and prevention. This means guiding families through those well-child visits, administering those critical immunizations we mentioned, and meticulously monitoring a child's growth and development over time.
So it's really about building this kind of proactive shield around the child's health right from day one, not just, reacting when they get sick.
Exactly.
Yeah.
That's a great way to put it. And beyond that shield, they're also key in illness and injury prevention. They provide what we call anticipatory guidance.
Anticipatory guidance.
Yeah, it means educating parents on age-appropriate safety measures, like preventing falls when a baby learns to roll, or identifying choking hazards before a toddler starts putting everything in their mouth, or safeguarding against burns, getting ahead of potential issues.
Got it. Proactive.
They're also essential in alleviating suffering. This covers effective pain management, sure, but also providing crucial emotional support, not just to the child, but the whole family during really challenging times. And importantly, pediatric nurses are powerful advocates.
How so?
Well, this could mean advocating for policy changes that benefit child health generally, or maybe connecting individual families with vital resources they need, whether that's specialized therapy or maybe financial aid.
Okay.
And finally, they provide immense family support,
Yeah.
offering education and emotional guidance throughout the child's health journey, whether it's just a brief illness, a hospital stay, or managing a chronic condition. It's truly a comprehensive, holistic approach. It addresses the entire family unit.
That deep connection to the family brings us perfectly to our next point. And here's where I think it gets really interesting. This philosophy of family-centered care, it sounds intuitive, doesn't it? I mean, of course, families are central. But what does it truly mean in practice? Like, what's the fundamental shift in thinking for the healthcare providers?
Yeah, it sounds simple, but the shift is actually quite profound. The fundamental idea, and it's a powerful one, is that the family is the constant in the child's life.
Right.
Healthcare providers, like nurses and doctors, were temporary participants.
Interesting perspective.
It shifts the dynamic significantly,
Yeah.
acknowledging that parents or guardians are the true experts on their child's daily life, their preferences, their history. It's not about the healthcare team just dictating care.
Yeah.
It's about collaboration and real partnership.
Mhm.
And this whole philosophy, it's built on three core principles. First, there's enabling.
Enabling.
Yeah, enabling. It means supporting parents' existing abilities, recognizing their strengths, what they already do well, and then helping them acquire new skills as their child grows and their needs change.
Okay.
The goal is really to foster their confidence in caring for their child, no matter what the health challenge might be.
Makes sense.
Second is empowerment. This involves building that parental confidence, sure, but also giving them real control over their child's care decisions, making them active, integral participants in the process, not just, passive recipients of information.
So they have a real voice.
They have a voice, and it's listened to. And third, critically, is mutual respect. This means acknowledging the unique expertise of both sides. The family knows their child best, period.
Right.
And the healthcare team brings their medical knowledge and skills. It's a partnership built on trust and shared decision-making.
Those principles sound fantastic, almost, aspirational. But I can imagine in a busy hospital setting, it must be challenging sometimes to truly empower parents while still ensuring medical safety. Are there common hurdles, and how do teams navigate those to bring these principles to life?
That's a really perceptive question. And yes, absolutely, there can be hurdles. One common challenge is just time constraints in a busy environment. Another could be, differing levels of health literacy among families. But successful teams, they overcome this by really prioritizing clear, jargon-free communication. And by genuinely valuing the family's input, even if it requires maybe a little more time up front.
Can you give an example?
Yeah, absolutely.
Yeah.
It's things like involving parents in daily care routines during a hospital stay, like bathing or feeding their child rather than the nurse just sort of taking over everything.
Okay.
It's asking about cultural practices or beliefs before making care decisions to make sure the care is culturally sensitive and appropriate for that family. And honestly, it's as simple yet profound as consistently using the child's and the family's preferred names and language. It makes them feel seen, respected, heard right from the very first interaction.
Yeah, those small things matter.
They really do. These actions reinforce that they are valued members of the care team. I think the key insight here is that family-centered care is about mutual respect and genuine partnership. And that ultimately leads to better outcomes for the child.
Okay, building on that, and it seems closely related to minimizing stress for the kids, we have this concept of atraumatic care. The name itself tells you a lot about its intention, avoiding trauma. But how is it formally defined? What are its main goals when caring for children?
Yeah. Atraumatic care is pretty much exactly what it sounds like. It's all about preventing or minimizing both physical and psychological distress for the child and their family throughout their entire healthcare experience.
Oh, okay.
And the impact of a traumatic healthcare encounter, it can last long after the physical issue has healed. It could potentially lead to fear of future medical visits or even lasting emotional scars. So this approach is really crucial. Its goals are very clear. The first is to minimize separation from the family.
Right, that seems huge for kids.
Oh, absolutely. For young children especially, being separated from their primary caregivers can be incredibly distressing. It can even be detrimental to their well-being, sometimes leading to things like developmental regression. The second goal is to promote a sense of control in the child and family. This means giving them choices whenever possible, even small ones, to help them feel less helpless and more involved in their own care.
Like what kind of choices?
Well, for a child, maybe being able to choose which arm gets the shot or what flavor of medicine they take if there's an option. It seems small to us, but it can make a huge difference in their perception of the whole experience.
Yeah, I can see that.
And the third goal is to directly prevent or minimize bodily injury and pain. This is all about making procedures as comfortable and pain-free as we possibly can.
So how do healthcare providers actually achieve this in practice? What are some of the tangible techniques they use to deliver this atraumatic care, going beyond just the good intention?
Right, it's about action. They employ a variety of thoughtful and evidence-based techniques. For instance, preparing the child for procedures using age-appropriate explanations is key. This might involve using medical play, where maybe the child can act out the procedure on a doll first. That helps them understand and gain a sense of control over what's about to happen.
Ah, like a rehearsal.
Kind of, yeah. And effective pain control is absolutely paramount. Utilizing methods like topical anesthetics, things like EMLA cream applied to the skin before needle sticks,
Hmm.
distraction techniques like engaging them with a video or a toy, and comfort positioning, where the child is held securely in a comforting way, maybe by a parent, during a procedure.
Hmm.
Another crucial technique is allowing parent presence during procedures whenever it's safe and, importantly, desired by the family. Just having that familiar, calming presence is often the best comfort a child can receive.
Yeah, definitely.
And finally, utilizing child life specialists. These professionals use therapeutic play to help children cope with stress, express their fears, and sort of normalize the healthcare environment. The key insight here, I think, is that atraumatic care acknowledges and actively addresses the emotional landscape of illness and procedures for children and families.
Communication is obviously key in any relationship, but wow, it feels like a dynamic beast in pediatrics. How does it adapt when you're talking to, say, a newborn versus a curious toddler, or even a sometimes sullen teenager? It really can't be one size fits all, can it?
Oh, definitely not. And mastering it requires really different approaches for different developmental stages. When communicating with parents, the approach is built on active listening, showing empathy, avoiding judgment that's huge,
Uh,
and using open-ended questions to encourage them to share their concerns and insights freely. With infants, communication is primarily nonverbal, right? Gentle touch, maintaining eye contact, using a soothing, calm voice. These are paramount because they respond mainly to sensory cues and comfort. Now, for toddlers, typically kids under 5, explanations need to be very concrete and simple. They have a very egocentric view of the world and a limited understanding of abstract concepts.
okay, concrete, like how?
Well, think about a time maybe a child scraped their knee. Instead of explaining nerve endings and inflammation,
Huh.
you might simply say something like, "We're going to put a magic Band-Aid on your OE to make it feel all better."
Yeah,
Simple, relatable.
got it.
As children enter the school age period, they're developing more logical thought. So explaining the reasons behind rules and procedures and really encouraging their questions becomes very effective. They want to understand the why.
Hmm.
When it comes to adolescents, respecting their privacy and allowing them to participate in decisions about their own care is crucial. It fosters their growing autonomy and sense of self-control.
That makes sense. Treat them more like adults in that respect.
Exactly. And finally, for almost all children, play serves as this kind of universal language. It can be used to assess their understanding or maybe their fears, explain complex procedures in a non-threatening way, and build trust between the child and the healthcare provider. It's just a really powerful tool for connection and understanding.
Wow.
So the key takeaway: effective communication in pediatrics is about meeting the child and family where they are developmentally and emotionally.
Okay, so when you're examining a squirming infant or maybe a curious toddler, that traditional sort of rigid head-to-toe examination that we might be used to with adults, it doesn't always seem practical or maybe even advisable, right? It sounds like it needs a more specialized touch, maybe even an altered sequence.
Exactly, you hit the nail on the head. For infants and toddlers, the clinical exam has to be flexible. It needs to be adapted to minimize distress and, honestly, to get the most accurate readings.
Okay.
For instance, the order of taking vital signs is specifically adapted. We usually assess the respiratory rate first, while they're ideally calm and often still.
Ah, before they get upset.
Precisely. Then the apical pulse, that's the heart rate, fell to the chest. Then blood pressure, and finally temperature. This order prevents crying or agitation from potentially skewing that initial critical respiratory and heart rate data. And the environment itself is also crucial. It needs to be warm, maybe child-friendly if possible, definitely private. And adapting the child's position to their age and developmental stage, maybe examining them on a parent's lap instead of a cold table, makes a huge difference in cooperation and comfort.
Yeah, I bet.
The key insight here really is that minimizing distress is paramount for accurate assessment in young children.
When we talk about children's health, what truly distinguishes their vital signs from adults? I imagine normal must look quite different for a tiny baby compared to, say, a school-age child. That's kind of fascinating.
Oh, it is truly fascinating how dynamic their physiology is. What's considered normal for a child changes dramatically with age. These are really key markers that illustrate the incredible physiological differences, not just between children and adults, but even across different pediatric age groups.
Okay, give us some examples.
Sure. So for an infant, a normal heart rate can range anywhere from 100 to 180 beats per minute.
Wow, 180.
Yeah, sounds high, right? Their respiratory rate is typically 30 to 60 breaths per minute. And we'd consider hypotension, or low blood pressure, as a systolic blood pressure below 70 millimillichastri.
Right.
Now, move to a toddler. Their heart rate slows down a bit, maybe 80 to 140 beats per minute. Their respiratory rate is maybe 24 to 40. And the threshold for hypotension becomes slightly higher. It's usually calculated as below 70 plus their age in years times 2 millimillichastri.
A formula. Interesting.
Yeah. And then by school age, their vital signs are starting to get closer to adult ranges. You're looking at a heart rate of maybe 75 to 120 BPM and a respiratory rate of 18 to 30.
Wow, that really underscores the point you made earlier. Children are absolutely not just miniature adults. Their systems are running at such a different pace, especially when they're very young. It's not just smaller, it's fundamentally different physiology.
Indeed. And these ranges are a constant reminder for us in healthcare that we simply cannot apply adult norms to children. A heart rate that would be concerningly high for an adult might be perfectly normal, even expected, for an infant, reflecting their higher metabolic demands and faster development. The key takeaway here is that pediatric vital signs are age-specific, and understanding these ranges is absolutely foundational to identifying illness.
Watching a child grow is just incredible, isn't it? Every day seems to bring a new skill or a new size. But what are the measurable signposts, the things healthcare providers use to track healthy growth and development beyond just a quick glance?
Right, we need objective measures. And we look at several key indicators, keeping in mind that their trends over time are often more important than just single measurements.
Okay, trends over time.
Exactly. Weight is a critical one. An infant typically doubles their birth weight by about 5 to 6 months of age. Doubles, and then triples it by 12 months. Any significant deviation from these expected patterns can signal important issues. Maybe failure to thrive if they're not gaining enough, or potentially concerns about overfeeding if they're gaining too rapidly. So we always plot these measurements on World Health Organization, or WHO, growth charts for kids under 2, looking for those trends and consistency over time, not just isolated data points. For height or length in infants, they generally grow about 1 inch per month during their first 6 months.
An inch a month.
Yeah, rapid growth. And by their first birthday, their length is usually increased by about 50% from their birth length. Here, consistency in measurement technique is really crucial because even small errors can skew the data and the resulting growth curve. Head circumference is another vital measurement, especially because it reflects brain growth.
Oh, okay.
It increases by approximately 0.6 inches per month during the first 6 months. Rapid changes, either an unusually fast increase or maybe a plateau in growth, can indicate conditions like hydrocephalus, which is excess fluid in the brain, or microcephaly, where the brain is unusually small.
So that's measured regularly?
Yes, head circumference is measured at every well-child visit until the child reaches 2 years of age. Finally, we monitor fontanelle closure. Those are the soft spots on the baby's head.
Right.
The posterior fontanelle, the smaller one at the back, typically closes by around 2 months old. The larger anterior fontanelle at the top usually closes later by approximately 18 months. Delayed closure, or unusually early closure of either fontanelle, can sometimes be indicators of underlying medical conditions.
Beyond just size and those physical measurements, their physical abilities literally explode in the first year. What are the key motor development milestones we see?
Oh, indeed. It's a period of truly dramatic physical advancement. In terms of gross motor skills, those involving large muscle movements, infants gradually achieve head control, improving significantly over the first 3 months. They typically roll from front to back at around 5 months and then back to front, usually by 6 months. They can often sit alone without any support by 7 months.
Sit up alone, okay.
Yeah. And by 9 months, they often start to creep on their hands and knees. Pulling themselves up to a standing position often happens around 10 months, and they might walk with support by about 11 months.
Holding on to furniture.
Exactly. And that monumental milestone of walking completely alone generally occurs around 12 months, although the normal range is quite broad, maybe 9 to 15 months is typical.
Right.
Significant delays in these gross motor milestones might prompt a referral for physical therapy or perhaps further developmental evaluation. Then you have the fine motor skills, which involve those smaller, more precise movements, especially with the hands. The grasp reflex, which is present at birth, typically fades by 2 to 3 months as voluntary grasping emerges.
So they start reaching intentionally.
Exactly. Infants usually learn to transfer objects between their hands at around 7 months. A crude pincer grasp, using the thumb and forefinger to pick things up, develops by about 8 to 9 months, and it becomes much more refined by 10 to 11 months.
Like picking up cereal.
Precisely. And by 12 months, they are often capable of building a simple 2-block tower. Delays in fine motor skills can sometimes indicate neuromuscular issues or even vision problems, highlighting how interconnected all aspects of development really are.
So what does all this mean for their emotional and social world? How do these rapid physical and cognitive changes tie into their psychosocial development, especially in that really foundational first year of life?
That's a great question, and this is where Erickson's theory of psychosocial development offers some really profound insights. For infants, from birth to 1 year, the primary developmental stage is trust versus mistrust.
Trust versus mistrust.
Right.
Okay.
This stage is fundamentally about forming a secure attachment to their primary caregivers. Consistent, responsive caregiving, meaning their needs for food, comfort, closeness, are met predictably and lovingly builds a sense of trust in the world and in other people. Conversely, if an infant's needs are inconsistently met or ignored, it can lead to a sense of mistrust and insecurity about the world.
So consistency is key.
Absolutely. And in a clinical setting, understanding this stage is critical. It means encouraging parental presence during hospitalization whenever possible, actively promoting bonding between parent and child, and responding promptly to an infant's cries and needs to reinforce that foundational sense of trust.
And how do their little brains start making sense of the world around them during this incredibly rapid period of development? What did someone like Piaget say about that?
Jean Piaget's theory of cognitive development describes this period as the sensoromotor stage, which spans from birth all the way to about 2 years old.
Sensoromotor. Makes senses and movement.
Exactly. It's a fascinating time when infants learn primarily through their senses and their motor activities. In the very first month, they are largely reflexive, acting solely on innate reflexes like sucking and rooting. For about 1 to 4 months, they enter what Piaget called the primary circular reactions phase. This is where they repeat pleasurable behaviors centered on their own body, like maybe sucking their thumb just because it feels good. Between 4 and 8 months, secondary circular reactions emerge. Now they repeat actions to make interesting things happen in their environment, like shaking a rattle over and over to hear the sound.
Cause and effect starting.
Yes. And then, from about 8 to 12 months, we see coordination of reactions. Here they start to engage in intentional, goal-directed problem solving. And a really crucial concept known as object permanence develops.
Object permanence.
Well, yeah.
That's where they know something still exists, even if they can't see it.
Exactly, like knowing a toy is still there even when you hide it under a blanket.
Yeah.
Before this state, it's sort of out of sight, out of mind.
Right.
So for healthcare providers and parents, the implication here is to provide age-appropriate toys and opportunities that stimulate this sensory exploration and help them understand cause and effect, fostering their cognitive growth. The key insight, I think, is that development is a continuous, interconnected process where physical, social, and cognitive milestones all build upon each other.
Okay, let's talk about immunizations. This is a topic that's, well, often discussed, sometimes debated, but strip that away, what's the core purpose of vaccines? And what's the pediatric nurse's very specific, hands-on role in ensuring this vital protection happens?
Right, let's get straight to the core. Look, immunizations are basically a superpower for kids. Their primary purpose is to prevent morbidity, that's illness, mortality, death, and the severe complications that can come from communicable diseases.
Okay.
But they don't just protect the individual child. They also play this profound role in protecting vulnerable populations in the community through what we call herd immunity.
Herd immunity. Explain that a bit.
Yeah, basically, if enough people in a community are vaccinated against a particular disease, the spread of that disease is significantly reduced, sometimes even stopped. This protects those who can't be vaccinated, maybe infants too young or people with certain medical conditions. It's an incredibly powerful public health tool. Now, the nurse's role in this process is multifaceted and absolutely vital. It starts with meticulously following the recommended CDC immunization schedule. Before giving any vaccine, they must obtain informed consent. This involves providing the family with vaccine information statements, or VIS sheets, for each specific vaccine, clearly explaining the benefits and potential risks.
Okay, the VIS sheets.
Exactly. Then, using the correct site on the body, the right gauge of the needle, and employing an atraumatic technique like we talked about earlier to minimize pain is also key.
Right.
After giving the vaccine, meticulous documentation is required. This includes the vaccine-specific lot number, the site it was given, and any reactions observed immediately afterwards.
Lot number. Okay, for tracking.
Precisely. And if an adverse event does occur, it must be reported to VA-ERIS, the Vaccine Adverse Event Reporting System. That's a national program specifically designed to monitor vaccine safety after they're licensed.
Can you give us just a few crucial milestones in that vaccine schedule, maybe the ones that are really foundational for parents to know about early on?
Certainly. Some of the earliest and most crucial milestones include the hepatitis B vaccine, which is often given right at birth or shortly after.
Okay, Hep B at birth.
Then, the first doses of DTaP that protects against diphtheria, tetanus, and acellular pertussis, or whooping cough Hib, which prevents Haemophilus influenza type B infections like epiglottitis and meningitis. Rotavirus, which prevents severe diarrhea, IPV for polio, and PCV, the pneumococcal vaccine, those typically begin at 2 months of age.
2 months is a big visit then.
It is. Then, around 12 to 15 months, children usually receive their first doses of the MMR vaccine for measles, mumps, and rubella, and the varicella vaccine for chickenpox.
Okay, around the first birthday.
Yeah. As children get older, Tdap serves as an adolescent booster, usually given around 11 to 12 years. And the HPV vaccine series, which protects against human papillomavirus, also typically starts around 11 to 12 years. And of course, we can't forget annual flu vaccines. Those are vital for everyone 6 months and older every single year.
When would a child not receive a vaccine? Are there specific situations, contraindications that would prevent immunization?
Yes, that's a really important question. There are definite contraindications where a vaccine should absolutely not be given. There are also precautions, which require careful consideration.
Okay, what are the main contraindications?
Key contraindications include things like a severe febrile illness, a very high fever at the time of the appointment. Also, being significantly immunocompromised, especially for live vaccines like MMR and varicella.
Live vaccines.
Okay, yes, those contain weakened forms of the virus. Also, a history of a severe allergic reaction, like anaphylaxis, to a prior dose of that specific vaccine or one of its components, or pregnancy, again, specifically for live vaccines.
Got it. And precautions, how are they different?
Precautions are conditions that might increase the risk of an adverse reaction or potentially decrease the vaccine's efficacy, but they don't necessarily prevent vaccination altogether. These usually warrant a careful discussion between the family and the healthcare provider to weigh the specific risks and benefits for that child. The key takeaway here, though, is that immunizations are a remarkably safe and effective way to protect children and communities with clear, established guidelines for administration and valid exceptions.
Now, beyond prevention, sometimes kids just get sick despite all our best efforts, right? What are some of those common communicable diseases we should know about that frequently affect children, and maybe what makes each one distinct?
Yeah, it happens. Let's touch on 3 classic examples often seen in pediatrics, focusing on what makes them distinctive. First, varicella, much more commonly known as chickenpox.
Chickenpox, okay. Less common now with the vaccine.
Much less common, thankfully, but still happens. It's caused by the varicella zoster virus and is transmitted easily through airborne particles or direct contact with the fluid from the blisters. Symptoms typically include a fever, general malaise or feeling unwell, and that distinctive, very itchy rash we call pruritic rash. It classically progresses from small red spots, called maculas, to fluid-filled blisters, or vesicles, and then finally they crust over.
Right, the crusting stage.
And a key point for controlling spread. A child is contagious from about 1 day before the rash even appears until all of the lesions have fully crusted over. That's a critical period for infection control. Next up, there's fifth disease. This one's caused by a virus called parvovirus B19. It's transmitted by droplet, like from a cough or sneeze.
Fifth disease. What? The
It
now?
was historically the 5th in a list of common childhood rash illnesses described back in the day. Its most characteristic symptom is this bright red, slapped cheek appearance on the face.
Ah, okay, seen pictures of that.
Yeah, it's pretty distinctive. That's often followed by a lacy-looking rash on the body. Now, what's particularly important about 5th disease and different from chickenpox is that it's most contagious before the rash appears. Once that slapped cheek rash develops, the child is generally no longer contagious.
Oh, interesting. So they're spreading it before anyone knows they have it.
Exactly. That's a key differentiator from varicella. And finally, let's talk about hand-foot-mouth disease. This is typically caused by the Coxsackie virus, though other viruses can cause it too. It's transmitted by droplet or direct contact, usually fecal-oral route or respiratory droplets.
Hand, foot, mouth. Sounds descriptive.
It is. It causes distinctive, often painful sores or lesions in the mouth, and also a rash or blisters on the palms of the hands and the soles of the feet. Sometimes kids get a painful diaper rash with it too. Yeah, it can be quite uncomfortable, especially the mouth sores making eating difficult. And it is highly contagious. Outbreaks are really common in daycare settings or schools because it spreads so easily among young children. The key takeaway for all these: understanding the specific transmission routes and the contagious periods is absolutely vital for limiting the spread of these common childhood illnesses.
Okay, let's shift to pain. Pain is such a subjective experience for anyone, but especially for children who might not have the words or maybe the developmental capacity to truly describe how they feel. This seems like a unique challenge for healthcare providers. How do they objectively measure and effectively manage pain in this really vulnerable population?
You're right, it is a unique challenge, and it raises a really important question. It's actually one of the core principles in modern pediatric care. In pediatrics, pain is absolutely considered the fifth vital sign.
The fifth vital sign, along with temperature, pulse, respiration, blood pressure.
Exactly. It must be measured objectively and documented consistently, both at baseline, like when a child first comes in, and after any interventions are done to treat the pain. Now, while self-report is the most reliable measure, when a child is developmentally able to verbalize their pain,
Right.
for younger or nonverbal children, we have to rely heavily on behavioral cues and sometimes physiological measures. It's really about applying a systematic approach to something that is inherently subjective. The key insight here: pain assessment in children is complex, requiring age-appropriate tools and really careful, consistent observation.
So what are these specialized tools or scales that healthcare providers use? How do they actually assess pain in children of different ages who might not be able to just say, my pain is a 7?
Right, we need validated tools, and we have several, each tailored to different developmental stages. One of the most common, especially for younger kids, is the FLACC.
FLACC. Okay, what does that stand for?
Good question. FLACC is an acronym. It stands for Face, Legs, Activity, Cry, and Consolability.
Face, legs, activity, cry, consolability. Okay.
It's an observational scale. The nurse or provider observes the child and scores each of those 5 categories from 0 to 2. So the total score ranges from 0, meaning no pain behaviors observed, up to 10.
Can you give an example?
Sure. So for the face category, a score of 0 would be no particular expression or a smile. A score of 1 might be an occasional grimace or frown, and a score of 2 would indicate frequent or constant frowning, a clenched jaw, or maybe a quivering chin.
Okay, I see.
It's incredibly useful in situations like post-operative recovery, especially when kids are still groggy from anesthesia, or for any child who simply cannot verbalize how they feel, maybe due to age or developmental delay. It's typically used for infants from 2 months up to about 7 years old, or older if nonverbal. The key, though, is consistent observation by the healthcare team to try and reduce variability in scoring between different observers. Then, for slightly older kids, we have the Wong-Baker Faces Scale. I think many of us have seen those iconic faces, right? They're quite memorable.
Yeah, the smiley face to the crying face.
Exactly. This is a self-report scale designed for children aged 3 years and older, assuming they can understand the concept. The child points to the face that best matches how much pain they are feeling right now. The faces are typically mapped to a numeric scale from 0 to 10, from a big, smiling, happy face representing no pain, 0, all the way to a crying face with tears representing the worst possible pain, 10.
It's straightforward.
It is. But crucially, before asking the child to choose, you need to explain what each face means simply. And you have to ensure the child understands the difference between worst pain and maybe just being saddest or upset about something else. Some kids might choose a face based on their mood rather than their physical pain level, if you're not careful.
Good point. Clarification is key.
Exactly. And finally, for kids who can understand numbers, we have the Numeric Rating Scale, NRS. This is also a self-report scale, typically used for preschool-age children and up, usually those 5 years and older, though some bright 4-year-olds can grasp it who understand basic number concepts and quantity.
Just the 0 to 10 scale.
Yep. They rate their pain on a scale from 0, meaning absolutely no pain, to 10, meaning the worst possible pain they can imagine.
Okay.
To ensure the child truly grasps the concept, we often use tangible examples that relate to their own potential experiences. For instance, you might say, okay, 0 is like sitting quietly and reading a book, feeling totally fine, and 10 is like, remember when you fell off your bike and broke your arm and had to go to the emergency room? That might be a 10. It helps them contextualize the numbers.
Okay, so once we've used these scales and assessed the child's pain level, how is it actually managed in children? And you mentioned relying on observation sometimes. Does that mean there are different types of pain that might require different approaches?
Yes, absolutely. Recognizing the type of pain is fundamental because it directly guides the treatment strategy. We generally categorize pain into a few main types. First, there's acute pain.
Acute, like
Yeah,
sudden.
exactly. Sudden onset, typically short in duration, usually lasting less than 3 months. Examples would be the pain from getting an IV started, an immunization shot, post-operative pain after surgery, or pain from a fracture. The goal with acute pain is rapid relief. We want to prevent both the physiological stress, things like increased heart rate, blood pressure, respiratory rate, and also the psychological trauma that can come from uncontrolled pain. Then there's chronic pain. This lasts for more than 3 months or maybe persists beyond the expected healing time for an injury or illness.
Like arthritis or something.
Exactly. Conditions like juvenile idiopathic arthritis, sickle cell anemia pain crises, or sometimes cancer pain that occurs between treatments would fall into this category. Here, the goal shifts a bit. It's not just about eliminating the pain completely, which might not be possible, but more about improving the child's daily function and their overall quality of life despite the pain. And sometimes you have mixed pain, which has features of both acute and chronic pain, like some types of cancer pain.
What can we do to help children manage pain without immediately jumping to medication? Are there effective non-pharmacologic interventions we can use?
Oh, these non-pharmacologic interventions are incredibly vital. They're often used in combination with medication for moderate to severe pain, or sometimes as the first-line approach for mild discomfort. They can be really powerful.
Like what works for different ages?
Okay, so for infants, simple yet powerful techniques include things like swaddling them snugly, offering a pacifier for non-nutritive sucking, skin-to-skin contact with the parent, gentle rocking, and simply holding them. These actions engage their natural comfort reflexes and can significantly reduce stress hormone release. For all ages, distraction is a huge one. This can involve singing songs, watching videos, playing with toys, or even just engaging them in conversation about something totally different. Cutaneous stimulation, like gently stroking or rubbing a painful area, can also provide comfort. Think gait control theory. Deep breathing exercises are effective too, and you can make them fun. Maybe blowing bubbles for toddlers or using pinwheels for preschoolers. For preschool-age children and up, relaxation techniques, guided imagery like imagining a favorite place, and storytelling can be very effective in shifting focus away from the pain.
Okay.
And for school-age children and adolescents, you can introduce more sophisticated strategies like music therapy, letting them play video games using virtual reality, or even teaching techniques like biofeedback and self-hypnosis in some cases. The key insight here is that non-pharmacologic interventions are a powerful first line of defense, often reducing the need for medication or at least enhancing the effect of any medication given.
And when medication is needed, what are the primary pharmacologic interventions used for pediatric pain? How does that differ from adults?
Right, when medication is necessary, we have several options, again, carefully tailored to the child's age, their weight, and the severity of the pain. Topical anesthetics are wonderful for minimizing procedural pain, like before needles. EMLA cream, which is a mix of lidocaine and prelocaine, is often applied under an occlusive dressing, like a clear bandage, about 30 to 60 minutes before things like needle sticks, IV starts, or lumbar punctures. It provides a good numbing effect on the skin. For mild to moderate pain, non-opioid analgesics are often the first-line choice. Acetaminophen Tylenol is very commonly used, but it's absolutely crucial to watch the total daily dose, which generally shouldn't exceed 75 milligrams per kilogram of body weight per day in children to prevent liver toxicity.
Okay, dose by weight is key.
Always. NSAIDs, like ibuprofen or naproxen, are also very effective, especially for children 6 months and older. They're particularly good for musculoskeletal pain and conditions involving inflammation. Now, for severe pain, think postoperative pain, significant trauma, or cancer-related pain, opioids like morphine, fentanyl, and hydromorphone are used. These are always dosed very carefully based on the child's weight. And a really crucial safety note here. Codeine should generally be avoided in children
Why is that?
because of variable metabolism risks. Some children are ultra-rapid metabolizers of codeine, meaning they convert it to morphine very quickly and efficiently, which can lead to dangerously high levels, causing severe respiratory depression or even death. Others metabolize it poorly and get no pain relief. So because it's unpredictable and potentially dangerous, healthcare providers almost always use safer opioid alternatives in children now.
Wow, that's critical to know.
It is. And whenever opioids are used, healthcare providers must meticulously monitor for potential side effects, especially respiratory depression, excessive sedation, and also constipation, which is a very common side effect.
It definitely sounds like pain management isn't a one-and-done scenario. How important is reassessment? And what about the documentation side of things?
Absolutely not one and done. Reassessment is non-negotiable. It's crucial for both safety and efficacy. In fact, failure to reassess pain after an intervention is considered unsafe practice. The timing of that reassessment is also critical and depends on the route the medication was given. For 5E opioids, we typically reassess at their peak effect, which is usually around 15 to 30 minutes after administration. Oral opioids take longer to work, so they're reassessed maybe in 30 to 90 minutes. And for topical anesthetics, reassessment occurs after their expected onset of action, maybe an hour or so after application. As for documentation, yes, it must be meticulous. Nurses need to document the pain score before the intervention and then again after the intervention, always using the same pain scale for consistency so you're comparing apples to apples.
Right.
They also need to record the patient's subjective report if they can give one, any objective findings they observe like changes in vital signs or behavior, the specific intervention given, dose, route, time, and most importantly, the child's response to that intervention. Was the pain relieved? Partially relieved, not at all.
And if it's not relieved,
Then the plan must be adjusted accordingly. Maybe a different medication is needed, maybe a higher dose, maybe adding non-pharmacologic measures. The goal is to ensure the child receives continuous and effective pain relief. The key insight. Continuous reassessment and precise documentation are the absolute cornerstones of safe and effective pediatric pain management.
all right, here's where I think it gets really interesting, and it's maybe a perfect example of how children are fundamentally not just small adults. They're airways. They're profoundly different, aren't they? And those differences have massive implications for how they breathe and how quickly they can get into trouble.
Oh, absolutely. What's fascinating, and also a bit scary, is that even seemingly minor structural variations in a child's airway, when you compare it to an adult's, can lead to critical compromise incredibly quickly. It's truly a testament to how specialized pediatric respiratory care really needs to be. Let's dive into some of these key structural and functional differences, focusing on their practical implications. First, a pediatric airway is often described as funnel-shaped, and importantly, its narrowest point is lower down at the cricoid cartilage, which is a ring of cartilage below the vocal cords.
Okay, funnel-shaped narrowest at the cricoid. How's that different from adults?
An adult airway is more cylindrical, like a straight tube, and its narrowest point is typically at the vocal cords themselves. This difference in shape and narrowest point means that any swelling from inflammation, infection, or irritation, even a small amount, can quickly obstruct a child's airway much more significantly than the same amount of swelling would in an adult.
So if I'm understanding correctly, that funnel shape, combined with the narrowest point being that rigid cricoid ring, means even just a little bit of swelling can have a much bigger impact on airflow than it would in an adult's wider, more cylindrical airway.
Exactly. It's like trying to breathe through a straw that's already narrow to begin with and then having it pinch even slightly tighter, especially at that non-expandable cricoid ring. The resistance to airflow skyrockets.
Wow.
Another critical difference. A child's tongue is relatively larger in proportion to their mouth compared to an adult's. This makes it much easier for the tongue to fall back and obstruct the airway, especially when they're lying flat, unconscious, or if there's any swelling in the mouth or throat.
Okay, bigger tongue, proportionally.
Yep. Furthermore, infants, especially newborns, are obligatory nose breathers for the first several months of life, maybe up to 4 to 6 months.
Obligatory nose breathers, meaning they have to breathe through their nose.
Pretty much, yeah. They haven't quite developed the coordination to reliably breathe through their mouth yet. This means even mild nasal congestion, like from a simple cold, can cause significant respiratory distress because they can't easily compensate by mouth breathing.
Ah, okay. That explains why stuffy noses can be such a big deal for babies.
It really does. And powerfully illustrated by something called Puiseuil's law, it's a principle from physics about fluid flow through tubes, is the impact of diameter. Because a child's airway is already so much smaller in diameter, a small amount of edema, or swelling, drastically increases the resistance to airflow. For instance, just 1 millimeter of swelling in the newborn's tiny airway, which is only about 4 millimeters wide to begin with, can reduce its cross-sectional area by a staggering 60% or more.
60% from just 1 millimeter.
60%.
Huh.
Compare that to an adult airway, maybe 8 millimeters wide, where 1 millimeter of swelling might only reduce the area by maybe 20–25%. It's a huge difference in impact. The key takeaway here is absolutely that a child's airway is inherently much more vulnerable to obstruction and subsequent respiratory distress than an adult's.
So what does this all mean then for a parent or a healthcare provider on the front lines? What are the practical, real-world consequences of all these unique airway characteristics?
It means that vigilance is absolutely key. Constant assessment, careful monitoring. Even what might appear to be a seemingly minor issue, like that common cold we mentioned, can potentially escalate very quickly to critical airway compromise in infants and young children.
Right.
Therefore, early detection of any signs of respiratory distress and prompt, effective airway management, like suctioning the nose, positioning the child properly, giving oxygen if needed, are not just important, they are absolutely vital for preventing severe outcomes like respiratory failure.
Okay, so with such vulnerable airways, knowing the signs of respiratory distress seems absolutely crucial for any caregiver, parent, or professional. What are those early warnings, and how do they progress maybe to signs of impending respiratory failure?
Absolutely. Recognizing these signs early can genuinely be life-saving.
Here.
The early signs of respiratory distress often include an increased respiratory rate. We call it tachypnea. That's frequently the very first measurable change you'll see.
Faster breathing.
Faster breathing. You might also notice nasal flaring, where the nostrils widen with each breath. That's the child unconsciously trying to reduce airway resistance and pull in more air.
Yeah.
Another key early indicator is retractions. These are visible indentations of the skin. You might see them between the ribs, that's intercostal, above the sternum or breastbone, suprasternal, or below the rib cage, subcostal. It happens as the child uses their accessory muscles much harder to try and breathe. The location and severity of these retractions generally increase as the work of breathing gets harder. Now, as respiratory distress worsens and starts progressing towards late signs or impending respiratory failure, you'll see more ominous signs. A decrease in oxygen saturation on the monitor, indicating the child isn't getting enough oxygen into their blood. Pallor, or paleness of the skin, which can then progress to central cyanosis. That's a bluish discoloration of the lips, the tongue, and the central body. Central cyanosis is a true medical emergency.
Okay, blue is bad.
Blue is very bad. Grunting sounds heard during expiration are another ominous sign. That's the child trying to keep their small airways open by creating a sort of natural peep, positive and expiratory pressure. In infants, you might observe head bobbing, where their head moves up and down in sync with their breathing efforts. It's a sign of severe distress as they use neck muscles to breathe. And finally, any altered mental status like sudden lethargy, extreme agitation, or just decreased responsiveness is a critical sign that the brain is not getting enough oxygen. The key insight: early signs of distress are a clear call to action. Late signs mean the child is in immediate danger and needs urgent intervention.
Let's dive into a couple of specific respiratory conditions now that often affect children and really vividly illustrate these airway differences you've been describing. Maybe start with one that sounds particularly scary.
Okay, let's start with acute epiglottitis. And yes, it is scary. This is considered a true pediatric emergency.
Epiglottitis. That's a little flap at the back of the throat.
Exactly. The epiglottis is the flap of cartilage that covers the windpipe, the trachea, during swallowing. In epiglottitis, it becomes rapidly inflamed and swollen, usually due to a bacterial infection. Historically, the primary cause was Haemophilus influenza, type B, or HISAB.
Ah, the Hib vaccine.
Precisely. Thanks to the widespread use of the Hib vaccine, true bacterial epiglottitis is much, much rarer now than it used to be, which is a huge public health success story. But it can still occur, sometimes caused by other bacteria.
So what does it look like?
It typically involves rapid inflammation and swelling of the epiglottis, which can lead to sudden, severe upper airway obstruction. Its key manifestations often include an abrupt onset of a very sore throat and a high fever. The child often looks toxic, very ill, and they may assume the classic tripod position.
Tripod position.
Yeah, sitting upright, leaning forward, with their chin thrust out, mouth open, and sometimes the tongue protruding slightly. They instinctively adopt this position to maximize their airway opening. You'll also often hear inspiratory stridor, that high-pitched, harsh crowing sound heard when they breathe in, indicating significant upper airway obstruction. And you might notice excessive drooling because swallowing is too painful, and a muffled hot potato voice. Management is an absolute emergency. Critically, you never, ever attempt to visualize the throat with a tongue blade or put anything in the child's mouth if epiglottitis is suspected,
Why not?
because it can trigger laryngospasm, a sudden spasm of the vocal cords, and cause complete immediate airway obstruction. It's incredibly dangerous.
Wow, okay. No tongue blades.
Definitely not. An airway management team, often including anesthesia and ENT specialists, must be called immediately, and intubation equipment must be readily available. Airway security is the absolute first priority. Again, prevention is key. The high vaccine remains the best defense. Okay, now let's compare that to croup, which is technically called laryngotracheobronchitis. This is much more common than epiglottitis.
Croup. Heard of that one. Sounds like a cough.
Yes, the cough is the hallmark. Unlike epiglottitis, croup is usually viral, often caused by the parainfluenza virus. It involves inflammation, but it's typically lower down in the larynx, voice box, trachea, windpipe, and the subglottic area, just below the vocal cords.
Okay, so different location than epiglottitis.
Exactly. Its classic manifestations include that very distinctive, barky, seal-like cough. It really does sound like a seal barking. Also, hoarseness of the voice, and usually inspiratory stridor, similar to epiglottitis but often less severe. And it characteristically gets worse at night. There's usually only a low-grade fever, if any.
So barky cough, stridor, worse at night. How's it managed?
Most mild cases of croup can actually be managed outpatient at home. Supportive care includes things like exposure to cool, humidified air, like sitting in a steamy bathroom, or going out into the cool night air, which can help reduce the swelling. For moderate to severe cases, especially with significant stridor at rest, corticosteroids like oral or intramuscular dexamethasone are often given to reduce inflammation. And sometimes nebulized racemic epinephrine is used in the emergency setting to quickly shrink the swelling and relieve the stridor. The key insight here: even though both croup and epiglottitis can cause stridor, their underlying cause, location of swelling, and urgency of management are vastly different, highlighting the need for accurate diagnosis.
It's truly astonishing how quickly a child's breathing can become compromised. But it's not just the internal systems like the airway that need specialized attention in pediatrics. What happens when a child's developing bones and muscles face challenges, like maybe an injury or a condition requiring immobilization? How does being still affect a growing body?
That's a really crucial point. Prolonged immobilization, whether it's from casting for a fracture, surgery, being in traction, or even just extended bed rest due to illness, has widespread physiological effects on almost every single body system. And these effects can impact a growing child much more significantly and sometimes differently than they might an adult whose growth plates have closed.
Okay, so what kind of effects are we talking about?
Well, for the muscular system, you see a fairly rapid decrease in muscle strength and endurance, muscle atrophy or wasting. And there's a significant risk of developing joint contractures, where the joint becomes stiff and limited in its range of motion. For the skeletal system, being non-weight bearing can lead to bone demineralization. The bones lose calcium and become weaker, increasing the risk for what we call pathological fractures. It can also lead to hypercalcemia, too much calcium in the blood as it leaches out of the bones.
Wow, even affects the bones that quickly.
It can, especially in growing bones. Then you have effects on other systems too. Cardiovascularly, there can be orthostatic intolerance, getting dizzy when trying to stand up an increased workload on the heart, and a higher risk for blood clots or thrombus formation. Respiratorily, decreased lung expansion, retention of secretions, and a higher risk of pneumonia, GI and GU systems. Constipation is common. Urinary stasis increases the risk for kidney stones and urinary tract infections. Metabolically, the rate can decrease, healing might be impaired, and skin breakdown over pressure points is a major concern. Neurologically, there's a risk for nerve compression. And psychologically, kids can experience regression, anxiety, frustration, and social withdrawal. The key insight here is that immobilization in children doesn't just rest a limb or the body, it profoundly affects their entire developing physiology and psychology.
So if a child does need a cast, say for a broken arm or leg, to immobilize it for healing, what are the critical considerations for care? What should parents and caregivers be really vigilant about?
Right, when a child has a cast, the primary purpose, obviously, is to immobilize the affected area to allow the bone or tissues to heal properly. However, there are absolutely crucial assessments that must be continuously monitored, particularly looking for signs of a very serious complication known as compartment syndrome.
Compartment syndrome, that sounds serious.
It is. It's a limb-threatening emergency.
Mm-hmm.
We often teach parents and assess for the 5 Ps of compartment syndrome, and knowing these is absolutely vital for anyone caring for a child in a cast.
Yeah.
Okay, so those 5 Ps are: 1, pain. This isn't just any pain. It's typically pain that is described as being way out of proportion to the underlying injury, and crucially, it's not relieved by standard pain medications, even opioids sometimes.
Pain out of proportion. Okay.
Yes. Number 2 is pallor. Pale, cool, or dusky-looking skin, distal to the cast, like the fingers or toes, indicating poor blood flow. 3 is pulselessness. The absence of distal pulses, like feeling the pulse in the foot or wrist, is a very late and extremely ominous sign. We hope to catch it before this point. 4 is paresthesia. This refers to abnormal sensations like numbness, tingling, or a pins and needles feeling in the affected limb. The child might complain their fingers or toes feel asleep or funny.
Numbness or tingling. Got it.
And 5 is paralysis. The inability to actively move the extremity distal to the cast, like wiggling fingers or toes. This is also a late and very concerning sign, indicating nerve damage or severe ischemia. Compartment syndrome itself is an emergency. It happens when increased pressure builds up within an enclosed muscle compartment, the space containing muscles, nerves, and blood vessels, enclosed by tough fascia. This pressure becomes so high that it compromises circulation, cutting off blood flow, leading to ischemia, lack of oxygen to tissues, and potentially irreversible nerve and muscle damage if not treated rapidly.
How is it treated?
It requires immediate medical attention, often involving an emergency surgical procedure called a fasciotomy, where the surgeon makes incisions through the skin and fascia to relieve the pressure and restore blood flow. Time is absolutely critical. The key takeaway here is potentially life or limb saving. Any pain that seems disproportionate to the injury, especially after a cast is applied or tightened and isn't relieved by medication, should be considered an emergency until proven otherwise. It's your child's body sending a critical red flag. An immediate medical evaluation can prevent permanent damage.
Let's quickly touch on maybe one specific musculoskeletal condition that commonly presents in children, just to illustrate the unique approaches needed for their growing bodies.
Okay, certainly. A good example is developmental dysplasia of the hip, DBH.
Yeah.
This refers to an abnormal development of the hip joint where the femoral head, the ball at the top of the thigh bone, doesn't fit securely into the acetabulum, which is the hip socket.
Yeah.
It can range from mild instability to a complete dislocation.
What causes it? Or who's at risk?
The exact cause isn't always known, but there are known risk factors. These include being born in a breech presentation, feet or bottom first, being female, and having a family history of DDH. It's much more common in girls.
How is it diagnosed? Usually at birth.
It's often screened for at birth and during early well-child visits using specific physical exam maneuvers performed by a trained healthcare provider. The Barlow maneuver involves adducting the hip, moving the leg inward, while applying gentle downward pressure, feeling for instability or dislocation. The Ortolani maneuver involves abducting the hip, moving the leg outward, while lifting the thigh, feeling for a clunk as a dislocated hip relocates back into the socket.
Barlow and Ortolani, okay.
Yes. Imaging studies are also used, typically ultrasound for infants under 6 months because their hip is mostly cartilage, and x-rays for older infants once the bones have started to ossify more.
And how is it treated?
For infants diagnosed early, usually under 6 months, the most common treatment is a Pavlik harness. This is a soft brace or harness that holds the baby's hips in a position of flexion, bent, and abduction, spread apart, which encourages the femoral head to settle properly into the socket as the baby grows. The harness is typically worn continuously, 247, for several weeks or months, usually around 6 to 12 weeks, until the hip is stable on exam and ultrasound. Nursing care involves teaching parents meticulous skin care under the harness straps and how to check circulation to the baby's feet. For older infants, or if the harness isn't successful, other treatments like a rigid brace or even a body cast called a spica cast might be needed, sometimes after surgery. The key insight: early detection through newborn screening and prompt, often non-invasive treatment like a Pavlik harness, can successfully correct DDH and prevent long-term complications like limping, pain, and arthritis later in life.
All right, let's shift gears now and talk about neuromuscular disorders. These conditions present, I imagine, their own set of really profound challenges for children and their families, impacting their movement, their development, and ultimately their quality of life.
They absolutely do. These conditions truly highlight the complex and vital interplay between the nervous system, the brain, spinal cord, and nerves, and the muscles they control. They significantly affect movement, coordination, muscle tone, and often have impacts on other developmental areas as well, requiring specialized, often lifelong support and care. One of the most common neuromuscular disorders diagnosed in childhood is cerebral palsy, CP. It's important to understand that CP is actually an umbrella term for a group of disorders. What they have in common is that they affect movement, muscle tone, and posture. And crucially, CP is caused by damage to the developing brain, usually occurring before, during, or shortly after birth. It's considered a non-progressive brain injury.
Non-progressive, meaning the initial brain injury doesn't get worse over time.
Exactly. The underlying brain damage itself doesn't worsen, but the manifestations, the effects on movement and function, can change over time as the child grows and develops. The most common cause is often related to prenatal anoxia, some period where the developing brain didn't get enough oxygen before birth. But it can also result from perinatal issues like birth complications or postnatal insults like infections or head trauma early in life.
So how does CP typically present? What signs might parents or doctors notice?
Manifestations vary really widely depending on the type and severity of the brain injury. But common signs often include delayed achievement of gross motor milestones like sitting, crawling, or walking. You might see abnormal motor performance, such as asymmetry in movement, toe walking, or developing a strong hand preference very early on, before 18 months. Altered muscle tone is a hallmark. This can range from spasticity, which is increased muscle stiffness and tightness, to hypotonia, which is low muscle tone or floppiness. You might also see the persistence of primitive reflexes, like the Moro or grasp reflex, beyond the age they should normally disappear. And often there are associated problems like seizures, vision or hearing impairments, feeding difficulties, or learning disabilities.
Wow, so it can affect a lot more than just movement.
It definitely can. Management is highly individualized and always multidisciplinary, involving a whole team. This might include medications to manage spasticity, like baclofen, oral or via an implanted pump, or botulinum toxin A, Botox injections into specific muscles. Physical and occupational therapy are absolutely essential for maximizing function and preventing contractures. Speech therapy is often needed for communication and feeding issues, and various adaptive equipment like braces, walkers, or wheelchairs may be required. Nursing focuses heavily on optimizing nutrition, maintaining skin integrity, preventing complications like contractures or respiratory infections, and supporting the family. The key insight: CP affects a child's movement, coordination, and potentially many other areas in diverse ways, requiring individualized, multidisciplinary, and long-term supportive care.
Yep.
Another significant condition we should touch on is myelomeningocele. This is the most severe form of spina bifida, which is a congenital neural tube defect.
Spina bifida, an opening in the spine.
Yes. In myelomeningocele, the spinal canal doesn't close completely during fetal development, and a sac protrudes through this opening in the back. Crucially, this sac contains not just spinal fluid and meninges, the protective coverings of the spinal cord, but also parts of the spinal cord and nerves themselves. This nerve involvement leads to varying degrees of paralysis and sensory loss below the level of the defect.
Okay. And you mentioned it's often linked with another condition.
Yes, it's very strongly associated with hydrocephalus, which is the buildup of excess cerebrospinal fluid in the brain, causing increased pressure. About 80–85% of infants born with myelomeningocele will also develop hydrocephalus, usually requiring surgical placement of a shunt to drain the excess fluid.
Wow, 80–85% is high. So the care starts right at birth.
Immediately. Preoperative nursing care for the infant born with an open myelomeningocele sac is critical. It involves placing the infant in a prone position on their stomach to prevent pressure on the sac. The sac must be kept covered with a sterile, saline-moistened, non-adherent dressing to prevent it from drying out and getting infected. Maintaining a strict latex-free environment is also crucial, as children with spina bifida have a very high risk of developing latex allergies, and rectal temperatures should be avoided.
Okay. And after the initial surgery to close the back?
Post-operatively, careful positioning, often continued prone or side-lying, is maintained to protect the surgical site. Meticulous wound care is essential, and daily head circumference measurements are absolutely crucial to monitor for the development or worsening of hydrocephalus. Families also need extensive teaching, particularly regarding management of the neurogenic bladder nerve damage, usually prevents normal bladder emptying, which almost always requires lifelong intermittent catheterization several times a day to prevent kidney damage. Bowel management programs are also needed. The key insight here is that myelomeningocele requires immediate, specialized, and lifelong multidisciplinary care due to its profound impact on neurological, musculoskeletal, and urinary bowel function.
And maybe touch briefly on one more, perhaps a progressive neuromuscular disorder, just to highlight the different challenges faced as children grow with these conditions.
Sure. A significant one is Duchenne muscular dystrophy, DMD. This is the most common and most severe form of muscular dystrophy diagnosed in childhood.
Duchenne, okay, what causes it?
DMD is an X-linked recessive genetic disorder. This means it primarily affects boys, inherited from their mothers, who are usually carriers but don't show symptoms. It's caused by mutations in the gene that codes for a protein called dystrophin. Dystrophin acts like a shock absorber in muscle cells, protecting them during contraction. Without functional dystrophin, muscle cells become progressively damaged and are eventually replaced by fat and scar tissue, leading to increasing weakness.
Excellent. So mostly boys. When do symptoms usually start?
Onset is typically between 3 and 5 years of age. Early signs might be subtle, like clumsiness, difficulty running or climbing stairs, or frequent falls. A classic sign that often develops is the Gower's maneuver, or Gower's sign.
Gower's maneuver.
Yeah, this is where the child, when trying to stand up from the floor, has to use their hands to walk up their own thighs to push themselves upright because their leg and pelvic muscles are too weak to do it directly. A waddling gait is also characteristic.
Ah, I see. And it's progressive.
Yes. Sadly, it is relentlessly progressive. The muscle weakness gradually worsens, typically affecting the proximal muscles, shoulders, hips, thighs first, and then spreading to distal muscles. Most boys with DMD lose the ability to walk and become wheelchair dependent by early adolescence, often around age 12.
Does it affect other muscles too?
Yes. Critically, the respiratory muscles and the heart muscle are also affected later in the disease course. Respiratory failure and cardiomyopathy, heart muscle disease, are the major causes of mortality, typically occurring in early adulthood, although lifespans have been extended somewhat with improved supportive care.
Is there a cure or treatment?
Currently, there is no cure for DMD. Management focuses on slowing the progression of the disease and managing complications. Corticosteroids, like prednisone or deflazacort, are the mainstay of treatment and have been shown to prolong muscle strength and the ability to walk for a few years. Physical therapy is crucial to maintain range of motion and prevent contractures. Respiratory therapy, including non-invasive ventilation later on, is vital, and cardiac monitoring and treatment are essential. Nursing care focuses heavily on promoting independence for as long as possible, monitoring for respiratory infections, which can be very serious, ensuring adequate nutrition, and providing psychosocial support to the child and family facing this devastating diagnosis. The key insight: DMD is a progressive, life-limiting condition that requires comprehensive, supportive, and palliative care focused on maximizing function and quality of life at every stage.
Okay, finally, let's bring it back down to earth a bit and talk about some really practical, everyday concerns and crucial safety considerations for infants, the kinds of things that almost every new parent or caregiver will encounter.
Absolutely. These are indeed topics that come up constantly, and just knowing the basics can alleviate a lot of parental anxiety and, more importantly, help prevent common issues or injuries. Let's start with something almost universal: teething.
Ah, yes, teething. Misery for baby and parents sometimes. When does it usually start?
The first teeth, usually the lower central incisors, those two bottom front teeth, typically emerge around 6 months of age. But there's a pretty wide range, maybe anywhere from 4 to 8 months is common for the first tooth. There's even a helpful little formula people sometimes use to estimate the number of teeth a child should have, though it's just a rough guide. Take the child's age in months and subtract 6.
Age in months minus 6. Okay, so an 8-month-old might have around 2 teeth.
Roughly, yeah. But again, lots of variation. Now, the symptoms commonly associated with teething include increased drooling, irritability or fussiness, maybe some gum rubbing or biting on objects, and sometimes a mild temperature elevation, usually not a high fever. If a baby has a high fever, look for other causes.
Right. So how can parents help soothe a teasing baby?
Management involves offering safe things to chew on, like cold teething rings, not frozen solid, just chilled, gently massaging the gums with a clean finger, or using age-appropriate hard teething toys. If the baby seems really uncomfortable, acetaminophen or ibuprofen can be given as needed for pain relief, always following the age and weight-based dosing guidelines carefully.
What about those teething gels? Are they safe?
That's a really important point. Crucially, parents should absolutely avoid using topical teething gels or liquids that contain benzocaine in children under 2 years old.
Benzocaine. Why?
Because benzocaine has been linked to a rare but very serious condition called methemoglobinemia. This is a blood disorder where the amount of oxygen carried through the bloodstream is significantly reduced, which can be life-threatening. The FDA has issued strong warnings against using these products in young children. So stick to the non-medicated comfort measures first, the key insight. Teething is a normal developmental phase, but knowing safe and effective comfort measures and what to avoid, like benzocaine gels, is essential. Okay, moving on to nutrition. This is fundamental for growth and development. The recommendation from major health organizations is for exclusive breastfeeding for the first 6 months of life.
Exclusive for 6 months.
Yes. And then continued breastfeeding, along with the introduction of complementary solid foods until at least 12 months of age, or longer if desired by mother and baby. If breastfeeding isn't an option or chosen, then iron-fortified infant formula should be used exclusively for the first 6 months.
Iron fortified, that's important.
Very important to prevent iron deficiency. Now, a critical safety rule regarding infant feeding is absolutely no honey for infants in the first year of life.
No honey before 1 year. Why is that again?
Because honey can contain spores of the bacterium Clostridium botulinum. In an infant's immature gut, these spores can germinate and produce the toxin that causes infant botulism, which is a serious form of paralysis. It's rare, but potentially fatal, so no honey before age 1.
Got it. No honey. When do solids start?
Solid foods are typically introduced around 6 months of age when the baby shows signs of readiness, like good head control, ability to sit up with support, and loss of the tongue thrust reflex. Usually you start with iron-fortified single-grain cereal like rice or oatmeal cereal mixed with breast milk or formula. Then you can gradually progress to pureed fruits and vegetables, and then pureed or finely minced meats.
One food at a time.
Yes, that's the recommendation. Introduce only one new food at a time and wait about 5 to 7 days before introducing another new food. This makes it much easier to identify any potential food allergies or sensitivities if a reaction occurs.
Makes sense.
And another key nutritional point. Avoid giving regular cow's milk as a primary drink until after 12 months of age.
Why wait on cow's milk?
A few reasons. Cow's milk is low in iron and can actually interfere with iron absorption, increasing the risk of iron deficiency anemia. It also has higher levels of protein and electrolytes than breast milk or formula, which can be difficult for an infant's immature kidneys to process effectively. And it lacks some essential fatty acids needed for brain development. So breast milk or formula should be the primary liquid until age 1, then whole cow's milk can usually be introduced. The key insight: infant nutrition has specific, evidence-based, non-negotiable guidelines designed to ensure healthy growth, development, and prevent potential illnesses.
Okay, this next one feels incredibly important. This is where our deep dive truly meets real life day to day, keeping children safe in their rapidly changing world. What are the key safety considerations, and how does that concept of anticipatory guidance play a role here?
You're right. Injury prevention is absolutely paramount, and it's a constant evolving need because a child's risks change so dramatically as they grow and develop new abilities. This is exactly where anticipatory guidance comes in. At every well-child visit, healthcare providers should be providing parents with information and advice on what developmental milestones to expect next, and crucially, how to keep their child safe before they reach those milestones and encounter new hazards. It's about staying one step ahead.
Okay, staying ahead, give us some examples for infants.
Sure. For sleep safety, the Back to Sleep campaign recommendations are absolutely critical to reduce the risk of SI days, sudden infant death syndrome. This means infants should always be placed on their back for every single sleep, nap time, and nighttime on a firm, flat sleep surface like a crib or bassinet mattress that meets safety standards. There should be no pillows, no heavy blankets, no bumper pads, no stuffed animals, nothing else in the crib with the baby. And co-sleeping or sharing a bed with an infant is also generally advised against due to suffocation risks. Back to sleep, firm mattress, nothing else in the crib. Got it. What about cars? For car seats, safety guidelines are very clear. Infants and toddlers should remain in a rear-facing car seat for as long as possible until they reach the maximum height or weight limit specified by that particular car seat manufacturer. This is usually well past age 2 for most children now. Rear-facing provides the best protection for their head, neck, and spine in a crash.
Rear facing as long as possible. Okay.
And then we have broader injury prevention strategies that evolve as the child grows. For example, regarding choking, it's essential to keep small objects, anything that can fit through a toilet paper tube, out of reach of infants and toddlers. And when starting solids, cut food appropriately. Slice grapes lengthwise, cut hot dogs lengthwise and then into small pieces. Avoid whole nuts, popcorn, hard candies, large chunks of meat. For falls, never ever leave an infant unattended on an elevated surface like a changing table, bed, or sofa, even for a second. Use safety gates at stairs. For burns, keep hot liquids like coffee or soup well out of reach. Turn pot handles inward on the stove, check bathwater temperature carefully, and secure electrical cords. And for drowning, tragically, it can happen very quickly and silently in even small amounts of water. So absolutely never leave a young child unattended near any water, including bathtubs, buckets, or toilets. Secure toilet lids, empty buckets immediately after use, and always provide constant, close supervision during bath time. The key insight is truly that. Anticipatory guidance, tailored to the child's specific developmental stage, is your single best tool for proactive child safety, always aiming to stay one step ahead of their next developmental leap and the new risks it brings. Hashtag outro.
Wow. What an incredible journey we've taken today through the really complex and, well, profoundly important world of pediatric care. From understanding the unique, delicate needs of a child's airway to decoding their sometimes silent cues of pain and navigating everything from routine immunizations all the way to the realities of complex neuromuscular conditions. We've truly seen how specialized, how thoughtful, and how compassionate care for children really has to be.
I hope so. We really hope you now have a much deeper appreciation for the immense detail and the comprehensive family-focused approach that's required in pediatric nursing and medicine, and how crucial it really is to consider the child not in isolation, but as part of a family unit, that constant presence in their life. These insights, they're not just for healthcare professionals, they're truly for anyone who cares for children, parents, grandparents, teachers, caregivers, helping you advocate for, understand better, and truly support the little ones in your life.
So, what does this all mean for you listening right now? Maybe consider this. Given how rapidly children change and how deeply interconnected their physical, their emotional, and their cognitive development truly is, what's maybe one small change you could make in how you observe or interact with a child in your life, now knowing the depth of their unique needs? Perhaps it's simply being a bit more attuned to those nonverbal cues, especially when they can't quite express themselves. Or maybe recognizing that a bad mood could actually be a subtle sign of something more going on, like pain or discomfort. Or maybe just being more intentional about engaging in play that actively stimulates their current developmental stage. It really is an ongoing journey of discovery, isn't it, for them and for us as we care for them.